Hi, everyone, and welcome to our Health Talk. My name is Elena, and my pronouns are she, her, and hers. On behalf of the Patient Education and Engagement Program here at University Health Network, thank you for watching this session on sickle cell disease. At UHN, we strive to provide safe and inclusive care, and that begins by honoring Indigenous peoples. Indigenous peoples are the original inhabitants of this land and for thousands of years have cared for this land. Although we are presenting this health talk in the digital world today, we want to acknowledge and remind ourselves and encourage you to do the same wherever you are currently located, that we are still on the traditional territory of many nations, including the Huron-Wendat, the Haudenosaunee, and the Mississaugas of the Credit River. This territory is governed by the Dish with One Spoon Wampum Belt Treaty, an agreement to share for, care for, and protect the resources around the Great Lakes in peace and respect. Today, this territory is still the home to many Indigenous peoples from across Turtle Island. During today's talk, we will hear how land and history of land migration have a strong connection to health for people with sickle cell disease. There are many connections between health and land for many others as well. For many years, Indigenous people have experienced health and other inequities. We continue to work to reconcile how to ensure health equity can be brought to Indigenous groups. September 30th is the National Truth and Reconciliation Day, also known as Orange Shirt Day. To learn more about the meaning behind this day and to deepen your knowledge about Indigenous health, we encourage you to check out orangeshirtday.org. We are grateful to have the opportunity to work, learn, and play on this territory. And thank you for joining me on acknowledging this land. Thank you to those who have submitted questions for our presenters. Normally, this is a time we would ask you to submit questions for the speakers in this session. We're doing things a little differently now. With our Health Talks new format, they are pre-recorded and then posted on YouTube. You can start submitting your questions at the beginning of each month. This will help us to see what people are interested in learning about most, allowing our guest speakers to tailor their presentations to the questions being asked. Now, moving on to our presenters. I'll give our presenters a moment to say hello and introduce themselves right now.
Hi, I'm Colleen Johnson. I'm a nurse practitioner in the Red Blood Cell Disorders Clinic at Toronto General.
Hi, my name is Sindhu Srikanthan. My pronouns are she, her, and hers. I am a social worker at the Red Blood Cell Disorders Clinic at the University Health Network.
Hi, my name is Bethany. I am 30 years old. I'm an ECE and I live with sickle cell disease.
Thanks, everyone. We have a great group of speakers today. For this session, we will talk about what is sickle cell disease, a patient's perspective about living with sickle cell disease, the social context, steps for change, and where to go for more information. I'll hand it over to Colleen now to start us off.
Thank you, Elena, for inviting us to this talk. We're very honored and excited to be presenting today. So sickle cell disease is not as common as high blood pressure, diabetes, but it does affect 7 million people worldwide. It is an inherited blood disorder. And in Ontario, it impacts about 3,500 to 4,000 people. And these numbers change as people move across provinces or with immigration. And you can see from the map on the side that the majority of patients with sickle cell disease are in the Toronto or Greater Toronto area. And with treatment and follow-up care, people with sickle cell disease can live long and full lives. We have a few patients in their 70s, and we have one patient who is 80 years old. Next slide, please. So what is sickle cell disease? It's a group of illnesses where red blood cells are not shaped the way they should. So within red blood cells sits hemoglobin, and hemoglobin is what carries oxygen from the lungs to the rest of the body tissues. Healthy hemoglobin shapes the red blood cells to be really smooth and bend easily while moving around the body. And you can see from the picture of this healthy red blood cell, it's more like a donut, and it can bend very nicely as it flows through the body. Someone with sickle hemoglobin, it's very different. Sickle hemoglobin can stick together and change the shape of the red blood cells so they do not move as easily, and so they do not transport the oxygen as easily. And you can tell in this picture how sickle hemoglobin can change the shape of the red blood cells. So the oxygen levels can be lower in patients with sickle cell. And sometimes we know when this is happening. We call this sickling. And sometimes we know when this is happening. We can tell from the symptoms of a patient, and sometimes we don't. And it's usually under times of stress, the body's under stress, that this type of sickling does happen. Next slide, please. So how does someone get sickle cell disease? It is an inherited blood disorder. There is a myth out there that it's contagious or infectious, and it's not. You have to develop sickle cell trait or sickle cell disease from your biological parents. So we get one gene from each parent that determines our type of hemoglobin. So in the picture to the side, I've chosen two people, male, female, who have one normal hemoglobin and one sickle hemoglobin. So they both have sickle cell trait. So when they have children, they can develop one child, a 25% chance of having a child with sickle cell anemia. Sickle cell disease and sickle cell anemia are the same thing. They have a 50% chance of having a child with sickle cell trait. And then they have another 25% chance of having a child without trait or without disease. And this is a good time that I get patients asking, well, what does sickle cell trait mean? Do they get sickle cell disease? And the answer is no. And under normal living conditions, someone with sickle cell trait does not have the same problems that someone with sickle cell disease has. Okay, next slide, please. So where and why is there sickle cell disease? We do know that this disease is more common in people with African or Caribbean background, but we also see it in the Middle Eastern, Mediterranean, and South Asian people. And why did this develop? This developed as a protection against malaria. So over time, the human body evolved to develop sickle cell trait, because trait gives some protection from malaria. And we can see from this map the areas that are more affected by malaria. So this shows where the populations have migrated from. And you can see from the green, we have no malaria in the Northern Hemisphere. So sickle cell trait does not serve any purpose. And in fact, it serves harm in that it can produce people with sickle cell disease. And sickle cell disease itself gives no protection from malaria. Next slide, please. So how do we know people have sickle cell disease? Well, since 2006, all babies born in Ontario are tested for sickle cell disease. This is really important as this gives us early diagnosis. So it means we have the ability to follow, we have the ability to educate parents and to treat the disease as early as possible. And I should make note that this testing is done on all babies regardless of skin color. Adults can also be tested for sickle cell disease or trait using a blood sample, and this is an easy conversation to have with your primary care provider. Next slide, please. So let's start to talk about the problems that happen with sickle cell disease. And remember, I said that sometimes we know people are having sickling of their red blood cells and sometimes we don't. Well, when patients are having pain, we know that their cells are sickling. And also remember, I said that red blood cells move very easily through the body to transport that oxygen. But when red blood cells are sickling, they can block those pathways. And when pathways are blocked of oxygen, that's when pain can happen. And this pain can be mild, moderate, or very, very severe. And the pain can last for hours to days to sometimes longer. Next slide, please. And so what situations cause patients' red blood cells to sickle when they have sickle hemoglobin? Well, anytime that there's oxygen's been reduced or narrowing of vessels happen, we know that patients' hemoglobin can sickle and cause pain. So situations like dehydration and infection, having stress to the physical body or even stress mentally causes chemical changes in the body. Weather changes. So if it's really cold, vessels will narrow. And again, that can be a situation where patients have more episodes of sickle cell pain. And patients will be able to sometimes know their patterns and know what's going to cause pain for them. And sometimes there's no cause at all identified. They will have pain and we or they cannot identify what caused it. We do our very best to help patients manage their pain at home, but sometimes they do need to come to hospital through the emergency department. We have some options, medicine options, and you'll recognize anti-inflammatories like Tylenol or Advil. And we also sometimes and often need to prescribe medication in the classification of opioids, which are prescribed by doctors or nurse practitioners. And opioids, unfortunately, come with some stigma. They are a medication that, if used incorrectly or for the wrong reasons, can cause addiction. But our patients are using them for the right reasons. They need to manage their sickle cell pain. So even some healthcare providers can have that stigma as well. When patients show up to the emergency department, identify themselves as having sickle cell disease, and they may ask for a certain opioid because they know that works for them. And there's always a patient knows what works for them. They've had this over and over, and they know kind of the cocktail of medications that will work. But it's not just medications that help. We also encourage patients to drink a lot, to hydrate them really well. If they're in hospital, sometimes we have to add oxygen. And other times, they may need more treatment as well. We also encourage patients to stay warm to try and increase those vessels and open them up. And also to get rid of that trigger. If it's an infection, we try and treat that as well. Okay, and sickle cell is not just about pain. One of the things that can happen is a very low blood level. The other thing about sickle hemoglobin is that it doesn't live as long as healthy hemoglobin. So patients can have critically low blood levels. And remember, I said sometimes we know patients are sickling as in having acute pain, but sometimes we don't. It can silently be causing damage within the body, which can happen over time. And so these are all the other areas that we have to keep in mind that the sickle cell disease could be damaging. There's also an increased risk of infection. Patients with sickle cell do not have a good functioning spleen, and the purpose of a spleen is to filter big bacteria. And if you don't have that, then you are at increased risk of infection. And in the most severe cases of sickle cell disease, a stroke can happen. Next slide, please. So what can we do for patients? And a lot of it is teaching patients self-care. It's really, really important to attend regular medical appointments at a comprehensive center like ours at Toronto General. We have a team of hematologists with expertise in sickle cell disease, as well as nurse practitioners, social work, transition navigators. There are also other clinics in the Ontario, and these regular appointments are really to order these screening tests to make sure there isn't silent damage happening to all the organs as well, and to really keep track of things like pain episodes. Next slide, please. There's lots more that patients can do when it comes to self-care, and these are in no particular order, but I will go through them. It's important to avoid people who are ill. They do not have a good functioning immune system, so avoiding infection from other people is important. Keeping immunizations up to date. The primary care practitioner, there is a list that they can provide these immunizations, and you can find that in the Ontario Health websites. It's important to drink lots of water and to eat a very healthy, balanced diet. Exercise is important, but really should try and avoid very strenuous activity. When we engage in strenuous activity, we sometimes can rob our muscles of oxygen, and these are opportunities that pain can happen. It's also why career planning for patients with sickle cell is important, as they shouldn't have physically strenuous jobs. And then maintaining good mental health, and then learning those tools to deal with the stress in the hopes that managing that anxiety, that depression, will help decrease the inflammation caused by those chemicals that happen in the body and cause sickle cell pain and damage. Next slide, please. We do have a medication called hydroxyurea that we do use for patients. It's a medication taken once a day. It works by decreasing the amount of sickle hemoglobin in a patient. It does come with some side effects, and we do have to watch their blood work, which is another reason why patients need to be followed quite closely in a clinic setting. The whole goal to decrease the hemoglobin S is to decrease the amount of pain that patients could be having and decrease the amount of organ damage that could be happening. In our clinic, we do have several other medications that are currently under clinical studies, and we discuss these potential studies with patients, and they are invited to participate because hydroxyurea does not work for everyone. Next slide, please. Another treatment option is blood transfusions, and we take this very seriously. Blood transfusions come with a lot of side effects for patients with sickle cell anemia. And it's also a very precious commodity. We rely on donors to provide blood. So occasionally, if a patient has very severe low blood levels, for whatever reason, fighting an infection, we do need to give blood transfusion. And then sometimes we routinely, every 4 to 6 weeks, need to give a blood transfusion for someone who's had very severe organ damage. When we give a blood transfusion, we are decreasing the percentage of hemoglobin S, therefore decreasing the number of times that damage can happen further to any of the patient's organ. Next slide, please. And finally, we do have treatments that cure sickle cell disease. Stem cell transplant is one option that is done at Princess Margaret Hospital. They must have a related donor, and unfortunately, this occurs very rarely in our patients, fewer than 1 in 5. It's a very high-risk procedure, and you can imagine how hard it is for patients or parents to decide to proceed with this type of treatment. Another option is gene therapy. This is only done in Canada under a research study. The advantage to gene therapy is that you're using the patient's own stem cells, and then they are taken from the patient and modified and then returned in the hopes that they can then produce normal hemoglobin. Okay, well, I'll turn it over to Bethany, and she can share her experiences.
Okay, hi, I'm Bethany. I have sickle cell disease. I am 30 years old and I'm an ECE. So I will be going into my story of living with sickle cell disease. Next slide. So I was born in Toronto in 1992, and I'm the youngest of 3 siblings. None of my siblings have sickle cell disease. All my siblings are half siblings, so I'm the only one with the full-blown disease. Before my parents knew I had sickle cell, I had ruptured bowels, collapsed kidneys and lungs, and then I was diagnosed with sickle cell at 3 months old. My gallbladder was removed at the age of 7. I know many people that have sickle cell. They have their gallbladder removed or their spleen is removed, as well as mine. So it's very common. In my childhood, I was in and out of the hospital pretty often. Probably from kindergarten to grade 4 were like the most toughest years. But currently, like right now, I'm doing really good. Right now, I'm an RECE. I do before and after school care. And to get my care for sickle cell, I usually go to Toronto General Hospital, and I do like blood work or just get my monthly 6-month appointments there. Next slide. Okay, so schooling and sickle cell. So I know a lot of people that have sickle cell, they are in and out of the hospital when it comes to school. That includes myself. Kindergarten through grade 4 were the really like toughest years. I was in and out of the hospital quite a lot. Thankfully, my mother advocated for me. One thing I want to tell people is make sure that you have someone to advocate for you if possible. Um, my mother advocated for me until I got to university and college. She advocated for me back when I was in school, going to school in Toronto. We weren't allowed to have like water bottles like on our desk. So my mom had to advocate for getting me a water bottle on my desk because again, with sickle cell, you need to be hydrated like all the time. Other ways she advocated for me was being able to go to the bathroom. Again, when I was in school, I think you're only allowed to have like 2 kids out at the washroom at the same time. And again, my mom would tell me like, if you need to go to the washroom, just go to the washroom. Like, don't worry about it. Don't listen to the teacher. Just go. Also, going outside for recess was difficult. Again, I had to go outside with the other kids. And again, because of the cold weather, I had to stay inside a lot of days. So my mom, again, would advocate for me to stay inside. So again, she advocated for me quite a lot. When I was going to high school, she still advocated for me, but it was manageable by then, my sickle cell, so I was pretty okay. I had one crisis in I think like the 12th grade, and I was in the hospital for about a week, and then I was okay. I went off to college in 2010, and I didn't have any crisis then, or if I did, it was probably minimal, and I managed it at home. I went off to university in 2012 and I graduated with my BA and I began to advocate there as well. I remember I was talking to Sinthu about a lot of kids who go off to university, they don't know to advocate for themselves or they're not aware of the services available. So I remember when I was in university and college, they have, I'm not sure what the name is called now, but when I was going, it was like the disability services and I would go and I would provide my paperwork showing that I have sickle cell or even that I had a learning disability as well. And I was able to get certain accommodations. So I was able to get like extra time on tests. If I was going to be away, I would message my counselor and let her know that I'm sick, and she would talk to like my professors for me. I also remember too, I was able to like go to the library and like do free printing and stuff and all that type of stuff. So there are a lot of services available. You just have to look and you have to just really advocate for yourself. Because in high school, I'm sure people like you have like you're still an adult or sorry, you're still a child, but when you go off to university, you're really by yourself. So it's really important to self-advocate for yourself and to get the proper accommodations that you need. Next slide. Okay, so employment in sickle cell. So I also work, like I mentioned before, I got my first job in 2012, and I did not disclose my sickle cell disease at the time because that job was only a casual job. So I would just pick up shifts here and there. So I didn't really feel the need to tell my supervisor. But even if I was sick, I would just not go to work or anything like that. But my sickle cell didn't really bother me a lot when I was doing that job, probably here and there. And then I got my current job in 2017 and I disclosed to HR that I have a chronic illness. Again, I spoke to my social worker in the past. I can't remember if it was Sinthu or Heather at the time, but I got like paperwork showing that I have sickle cell and I gave it to my HR and let them know that this is what I have. So they're very aware. I've had one incident actually where a manager did not allow me to go to a 6-month appointment I had for Toronto General. I remember I know with Toronto General, you book your appointments like 6 months in advance. So when I booked this appointment, I didn't have this job yet. So I had no idea that this day was like a PA day, for example. And I remember telling my manager, like, I have this appointment, I have to go. And she would like flat out like denied me. And she's like, no, you can't go. It's a PA day. So after talking to her like countless times, I finally said, like, I have sickle cell disease. Like, you can look in my file. And she's like, after she read it and she saw it, she apologized and I was able to go. So personally, I think a lot of people, like employers, don't understand that people have sickle cell and they're able to work and everything, but like they also have to go to their appointments. It's super important, like Colleen mentioned, like try not to miss those 6-month appointments. Luckily, I don't miss them. I'm very fortunate that I have a job where I have a lot of time off, like in the day, so I'm able to go. But I think employers need to be more understanding that chronic illnesses are real. Invisible illnesses are also very real. I live with an illness that you can't see on the outside, but it's very there, very real on the inside. Currently, I work part-time. It just works better for me and my health. I'm able to manage my self-care better, which I'll get into later, but I definitely think working part-time works for me. I understand everyone's life is different and they don't have the life I have. I know I live at home, so I don't have to worry too much about financial needs and stuff, but it's definitely been really helpful and really, for me at least. Okay, next slide. Okay, so self-care and sickle cell. So personally for me, my self-care is very important to me. Taking care of my mental, emotional, and physical care are very important. I went to the doctor in 2019. I had a lot going on in my life at home, and I thought I had anxiety, and I just always felt something was off. And I was later diagnosed with anxiety in 2019. My anxiety is moderate, and over the years, I've really learned how to manage it better. I personally, I went to group therapy. My doctor recommended me group therapy, so I went for a couple of weeks, and then I started to like look around for a therapist on my own. Right now, I do see a therapist every couple of weeks. And again, I understand therapy is expensive. I definitely feel like it's something that should be more accessible to all people. It's not cheap. I've gone through um, having therapists that charge a lot of money, that don't charge a lot of money. I know with even some workplaces, I think my workplace as well, they have this program. I think it's called the EAP or something like that. And you're able to use their services. I've used them a couple of times during COVID, and I've just called and spoken to somebody. So if you have those available to you, you should definitely use them. What else I do for my self-care is like I like to, well, I don't know if I like to work out, but I work out. I like to journal, seeing a therapist every couple of weeks. I like to connect with my family and my friends. That's helped me a lot. I also just like to relax a lot. I like to do a lot of nothing. So that also helps with my self-care and just, staying hydrated, like Colleen mentioned, take my medication. Also calling the doctors when I'm about to run low on medication. Personally, I know I don't call very often, but when my medication is getting low, I definitely like to call Toronto General and just let them know, and then I can get a prescription really quickly. I think those are like a lot of the main things I do. I have a lot of fun things, like I like to shop, I like to buy candles, but those are like the most important things that really help me take care of myself. Next slide. Okay, so my final thoughts. Personally, I feel like people like myself that have sickle cell, we do everyday normal activities. I go to work, I have friends, I have family, I have hobbies and interests just like anybody else. Most importantly, I think it's important to take care of your body and attend your appointments. And if you can't attend, definitely like reschedule them for sure. Definitely also, I know I'd like to call Toronto General and ask questions when my body's off. I've called Colleen a couple times. I'm like, something's wrong. And we like to talk about it and go over it. So I think it's so important to call. That's why they're there. That's why they have a whole separate line for you to call, like the health practitioners. Always advocate for yourself. I find that now I'm getting older. I manage my sickle cell pretty much on my own. Like my parents are there and things like that, but I manage it on my own. So I know like what I need. I know if I'm tired, I need a break. If I need to go outside and get some sunlight, if I need to go to bed early. Again, everyone's life is different. I know people have children. I don't have children, so I'm able to be a bit more flexible with how I like go about my day. Always advocate for yourself, like I said, in school also and in your personal life. And I feel like when people hear of sickle cell, they always hear something like negative, or I know I get negative comments towards me. And I like to think of it like sickle cell is not the end all be all. It's definitely not the end of your life. You're able to do a lot of things. You're very capable of a lot of things. And having a supportive network is great. I understand, again, people may not be as fortunate as me to have a supportive network, but there's a lot of groups online I've seen that have people that have sickle cell. You can reach out to them if you don't have close family and friends. So definitely get that if you're able to, and always just take care of yourself and like put yourself first. And remember, like, you are a priority. You are super important. Um, that wraps up my part of the presentation, and now I'll hand it off to Sindhu.
Thanks so much, Bethany. I'm going to be talking. May I have the next slide, please? Thank you. So I'm going to be speaking about the social context of sickle cell disease. So in Bethany's story, we heard a lot about advocacy, so much advocacy. Why is that necessary? So I'm hoping to kind of explore how sickle cell is situated in society. So first of all, we really need to talk about racism when it comes to sickle cell disease. And I first want to differentiate race as a social construct versus racism as an actual material disparity. So sickle cell disease is socially constructed as a Black disease. By what I mean by that is that, you know, since its discovery, it's been written about, spoken about as an illness that solely affects Black communities. But as Colleen had mentioned, sickle cell disease is a genetic disorder, and it can impact all people regardless of race or skin color. And in fact, there is a study that found that 1 in every 540 white British babies have a trait relevant for sickle cell disease. So all communities are potentially impacted. At the same time, we cannot take a colorblind approach. In the global north and in Ontario, we have to acknowledge that sickle cell disease disproportionately impacts Black communities in Ontario. So why is this all important? May I have the next slide? So it's important because anti-Black racism is really shaping a lot of the disparities that people with sickle cell disease experience. So I wanted to just spend a little bit of time just speaking to anti-Black racism. So what is it? It is a form of racism that targets African descent / Black peoples. It is found in all aspects of society. So it's in the employment sector, it's in education, it's in healthcare, it's in child welfare, it's in the justice systems. And they are really discriminatory beliefs, attitudes, prejudice, and stereotypes of Black people. It is rooted in, colonization as well as Black African descent people's experiences of enslavement. And it results in material inequalities. So differential access to opportunities, it results in different outcomes. Overall, it results in negative outcomes for Black folks. And then another part of anti-Black racism is the erasure. So again, Black people's experiences and their contributions are erased oftentimes. And all of this is to say that this context leads to inequitable care for people with sickle cell disease. And that's why people like Bethany have to do a lot of advocacy. Next slide, please. So I just want to give a few examples about how anti-Black racism really shapes negative outcomes for people with sickle cell disease in Ontario's healthcare system. And this is really just to give you an idea that it is systemic. So newborn screening, which Colleen mentions, identifies babies and starts life-saving treatment. Well, the recommendation was made in the 1960s, and it was a disease that was impacting mostly Caribbean Black folks at the time. Despite the recommendation and advocacy being made, it took Ontario 40 years to implement universal newborn screening for sickle cell disease, which saves lives. So again, this delay speaks to, anti-Black racism resulting in a lack of identifying and starting treatment. And unfortunately, a lot of, people died because they didn't have the diagnosis and the treatment. In the 1990s, there was a lot of pressure to dismantle, at the time, Ontario's only pediatric center for sickle cell disease. Similar clinics that, for blood disorders that impact white communities, such as hemophilia, they were never on the table. So again, you see that differential treatment based on who is affected by the disease. And finally, I want to say that today there continues to be ongoing deprioritization for sickle cell disease in the healthcare system. There is some positive developments, but there continues to be that current of, not a priority. And there continues to be, I would say, resistance to anti-racism that comes up in different forms. Next slide, please. And I also wanted to share some, examples that patients commonly tell us about their experiences of anti-Black racism in their care. And I'm drawing from a documentary that will be linked below, where patients with sickle cell disease in Toronto, they speak about their experiences where healthcare providers frequently treat patients with mistrust and as undeserving of care. Patients speak about how healthcare providers call security and may handcuff patients. So that's completely dehumanizing and, basically evoking the criminal justice system in a place of healing. Patients, Colleen mentioned the stigma of opioids. Well, this really intersects with anti-Black racism, where patients are frequently labeled as, a drug abuser or drug seeker when they're seeking care for pain. And when patients advocate, they may be written off as an angry Black person. So again, the racial stereotypes are popping up in care. And overall, the patient spoke to the negative view that healthcare providers hold with people with sickle cell disease. Next slide. So another social aspect that I wanted to speak about is supporting sickle cell disease as a disability. In Colleen's speak, she spoke about all the different complications that could happen. And also the pain is an episodic condition that is really triggered by environment. And in Bethany's talk, we learned about how, flexibility with the employer or the school or other adjustments really made work and school accessible for her. So it's really important to name sickle cell as a disability, and sickle cell is in fact a disability under human rights law. And why this is important is because when you name sickle cell as a disability and when it is received as a disability, infected folks can get accommodation, so flexibility and adjustment in the workplace or at school, and they may also get benefits, so financial support to help with the costs of disability, right? Because living with sickle cell disease also incurs a cost, and so overall, I want to say. It's important to name sickle cell as a disability because you get tools to help shape a good quality of life. Next slide. But unfortunately, our patients report numerous challenges. And again, I am reflecting on Bethany's advocacy, like the advocacy of her mom, as well as herself, right? Why do patients have to advocate so much? And patients report, they have challenges getting documentation to confirm their disability. They're constantly questioned by accommodation providers such as employers or schools. And this is related to a number of factors, as Bethany mentioned, and also highlighted by Colleen. Sickle cell disease, you may not see the impacts visibly. It is an invisible disability. So, an employer or a school, they may not look at a person with sickle cell disease and see them as how they imagine a disabled person would look like. So this is related to ableism, which is this discrimination against folks with disabilities in society. But also on top of that, there is an added layer of scrutiny where our patients, most of whom are Black, are not believed. And this is related again to the anti-Black racism where, folks with sickle cell who are also Black are just often questioned and not believed. And so really what this often ends up is a vicious ableist, and racist cycles. So these are all barriers for naming disability, sickle cell as a disability, barriers for a good quality of life. May I have the next slide? I did also want to speak a little bit about neighborhood context. This has implications in terms of the social determinants of health. So as Colleen mentioned, we do know that most of the sickle cell patients are living in the Greater Toronto area. And we also know there was some research that shows that patients are living in areas that are lowest income. So 41% of all patients in Ontario with sickle cell live in low income neighborhoods. So in Toronto, this is a map where we see that the red areas, which are lower income areas, they are actually under-resourced for social and health services. And they also have limited access to public transportation. And they are also home, we also know that they're home to racialized and immigrant communities. So if you are somebody with sickle cell, and you are in one of these lower income neighborhoods, this has implications in terms of your access to care, right? Imagine coming like you're just coming to Toronto General, which is in the blue area. There's not a lot of public transportation available, right? So that has all implications on your access to care and well-being. May I have the next slide? And then I also want to highlight Brampton. So we do know that most of the patients in Ontario with sickle cell disease, they live in Brampton. And in this map, we see that Brampton is mostly lower income. There's not a lot of, I don't really see any blue areas. So there's like poverty is an issue that is, in Brampton, and it is impacting patients' experience. Also, what is important to note about Brampton is that it's still developing its infrastructure. It does not have a lot of access to health and social care. And there's also very limited public transportation, right? So you can imagine if you're coming to Toronto for appointments. We do have a clinic at Brampton, but still Toronto General is serving a lot of the Brampton patients. Public transportation is an issue. Also access to mental health resources, just any kind of community programming, that's going to be a bit more challenging in Brampton. And a lot of our patients, do kind of rely on the Toronto networks as well. May I have the next slide? So I just wanted to also mention other intersections, right? So sickle cell, your experience can be shaped by gender, your experiences of caregiving. If you're a caregiver to someone with sickle cell, or you're a person with sickle cell who is a caregiver. Cultural identities also impact, how sickle cell may be understood in your community. The immigration and refugee experience is also very important. And that can also shape your access to care. Increasingly we're recognizing intellectual disability is coming up for people with sickle cell. And again, that's something that also experience how you navigate the healthcare system. If you're a member of the LGBTQ2S community, that is also going to shape your experience of care. And also as patients are living longer, a new layer that we're, it's great to see is the experience of aging with sickle cell. And there's also many other intersections as well. Next slide. So I wanted to talk, we spoke a lot about how society is, really constraining the well-being for people with sickle cell. I wanted to talk a little bit about steps for change. May I have the next slide? So I really think it's important, especially for healthcare providers, to learn about anti-Black racism. And I wanted to share like 3 main points to get started. So first of all, learning that race is socially constructed. So that means race, it's not biological, it's not genetic. It only exists to cut up and divide society. The second point is to acknowledge that anti-Black racism is real. So it exists in all of society. It exists in healthcare. It exists in education, the labor market, and so forth. And again, it results in actual disparity for African descent and Black people. And I think for healthcare providers, I don't think it's useful to spend time figuring out if something was racist or not, but really begin with that acknowledgement. And finally, I really think it's important to appreciate that the anti-Black racism that exists in today's society, it is rooted in Black people's experiences with colonization and enslavement. So, being in the ED and getting called a drug seeker, that is tied to, that's a continuity of colonialism and enslavement. Next slide. I also think, and this is for people living with sickle cell, their families, their social supports, and healthcare providers. I also think it's important to recognize the strengths of people with sickle cell, and we need to appreciate that people, groups, and communities are resourceful and resilient, and people develop strengths, especially in the face of adversity. And when we think about strengths, getting really specific, what are your knowledges? What are your unique skills and abilities? How do you cope? Who are the important people in your life? What kind of relationships do you have? What are your hopes and dreams? And I think, sometimes we get disconnected from these strengths that we all have. And I think it would be really, wonderful, like for healthcare providers, social support, and people with sickle cell disease, it's really important to identify their strengths and also amplify them. May I have the next slide? So that wraps up my social context section. And we're just going to be talking a little bit about some resources for more information. So I wanted to mention that these resources will be posted in the link below in the description. So the first item is the RBCD Hub. This is the official blog of UHN's RBCD clinic, and it's a space to connect about sickle cell disease as well as thalassemia and other red blood cell disorders in Ontario. I also wanted to direct your attention to UHN's anti-racism and anti-Black racism policy. UHN is the only hospital in the universe with an anti-racism / anti-Black racism policy. So this is very important. So this policy outlines UHN's commitment to understanding the histories of systemic racism and discrimination that results in unequal access for Black, Indigenous, people of color. Finally, I also wanted to mention UHN's anti-racism and anti-Black racism course. It's available for free, and UHN leaders can request this training by emailing ideateam@uhn.ca. I think this course can build capacity of emergency departments, general internal medicine, and other areas where people with sickle cell disease receive care. Finally, I wanted to mention Ontario Health Sickle Cell Disease Quality Standard. This was just released in January of this year. And patients, healthcare providers, anybody in the community can read this document to know what quality care looks like based on evidence as well as expert consensus.
Thank you, Sindhu. I'll continue on with these resources. There is access to a CAN-HEAM consensus statement. This is really meant for healthcare professionals, but it can also be read by any member of the public. It does give a summary of our best current practices that are recommended by a team of sickle cell experts. Next slide. This is a link to the documentary that Sindhu mentioned, and it talks directly about experiences of people with sickle cell disease in Toronto. Next slide. And these are three very important organizations that support and advocate for sickle cell disease within Ontario and as well as Canada. Next slide.
And last but definitely not least, you're always welcome to contact the Patient, Family, and Learning Centers at UHN They offer reliable and up-to-date health information to patients, families, healthcare providers, and members of the public. All their services are free and available in multiple languages. You can call, email, or visit their centers, and they're open Monday to Friday, 9 a.m. to 4 p.m. That brings us to the end of our presentation component of our health talk. As mentioned before, we had questions submitted from UHN staff, patients, caregivers, and the general public. So we will go through some of those questions now. Please note, if you chose to submit a question, we have removed your name and we've only included the question. So our first question, I am a social worker supporting patients to make healthy changes with their substance use. Are there specific considerations for patients with sickle cell disease? For example, increased risk of complications with intravenous drug use, increased rates of substance use in patients with sickle cell?
Well, this is a great question, and thank you so much for the work you do in this type of patient group. Patients with sickle cell who use any type of intravenous drug use, there is a very high risk of complications. And specifically, cocaine is a medication that can constrict blood vessels, so that can cause a full multi-organ failure. Heroin is a medication that really decreases oxygenation. So again, these put patients at high risk of not just pain, of not just organ failure, but head to toe organ failure. So it is very, very detrimental. And then increased rates of substance use in patients with sickle cell. No, there is not increased rates of substance use in patients with sickle cell disease as compared to the general population. Thank you.
I would also like to add that if you are supporting a patient with sickle cell disease who has, challenges with substance use, I think it's really mindful to have awareness of the drug seeker, drug abuser stereotype that patients routinely experience, and make that trauma-informed care is really important, and understanding that that experience is absolutely shaping their experiences of mental health care.
Thanks, Colleen and Sindhu, and I definitely agree that trauma-informed lens is really important. Okay, our next question, how do you tell others, friends, about sickle cell disease and explain why you might not be able to do certain activities at times?
Okay, I think that question's for me. So personally, I'm very honest with my friends that I have sickle cell. It's not something I hide. I'm not embarrassed. I'm not ashamed of it all. So I kind of just let them know that maybe I'm in pain today. Maybe I may have to wrap up an activity early if I'm not feeling well. Luckily, my friends, we don't do any activities that are super like strenuous. Like usually our activities are like going to dinner or something. So it's nothing that requires us to be outside for very long periods of time. We're not doing anything crazy. Like my friends are super chilled and laid back, so it's all good. They get it, they understand. My friends, I think personally, if you have to tell your friends that you have sickle cell and they don't understand, then they're probably not your friend. So I just feel like you will find your circle of people. But personally, my friends are really great people. I've had them for years, and they're very understanding. So I would just say be understanding, be open, be honest with them, be transparent. And I mean, if they don't understand, then they're probably not for you. But that's what I would do.
Thanks, Bethany, and I'm sure people will take a lot from your story that you shared earlier. Okay, our next question is, how does having sickle cell disease affect the experience of other common conditions or disease, such as diabetes or cancer? Does sickle cell disease change the way other conditions are treated or managed if someone has another health condition and sickle cell disease?
This is a really great question and something that comes up very frequently as we have more sickle cell patients living longer. And it's really important that when someone with sickle cell disease is diagnosed with anything like diabetes or cancer, that we have a connection to those other specialists to try and help them manage the patient, especially if it comes to things like surgery. We definitely need to be contacted prior to any type of surgery. We also need to help with any medications that they could be prescribed to see if it interacts with the medications that we use. And also if there is any disruption or decrease in the immune system of any medications that could happen. So really, it's important that we have a relationship with those other specialists and we make ourselves very available. And we also educate our patients that if they are diagnosed with anything, to please contact us so that we can be part of their plan of care.
Thanks,
Thank you.
Colleen. It really shows the importance of an interdisciplinary model of care for patients and healthcare providers. Okay, our next question. What does sickle cell disease pain feel like?
So this is a question I get quite a lot, even from my family. Kind of just how do you describe the pain? So personally for me, sickle cell kind of feels like a stabbing pain. Like imagine someone's taking like a really like sharp knife and they are stabbing you constantly in this one area of your body. It is constant. It hurts a lot. I know sometimes I've been in pain to the point where I'd like you to just cut the limb off. Like that's how bad the pain gets. Um, it's obviously not fun. It's not easy. I know with me personally, I'm in pain probably like every day, but sometimes my pain feels like a numbing pain, or it just, again, it's like a stabbing pain. Like there's some days you can describe it and other days you really just can't, and you just know what the pain feels like. But definitely like when it's a crisis, it's like a really sharp stabbing pain that like doesn't go away. So that's how I would best describe it.
Thanks, Bethany. Really appreciate that and hearing your story as well. All right, should people with sickle cell disease take iron pills?
This is a great question that I get asked quite a bit. Patients will often go to their family doctor or they'll go to the emergency department. They'll see, the healthcare professional will see that a patient's hemoglobin is lower than maybe a normal range of hemoglobin. And so they will assume a patient should take iron pills. And it is a very rare occurrence that someone with sickle cell disease needs iron. And so this is really important to have this conversation with your hematology team, with your sickle cell experts. And if we feel there's any indication, then we need to run a few tests. And then it's your hematologist that should determine whether you take the iron pills.
Thanks, Colleen. All right, this is our last question. My family doctor tells me that some of my health issues are related to sickle cell. My hematologist tells me that these are not related to sickle cell, that it could be something else, and tells me to go back to my primary care provider. How can I find out what's really going on in general?
This is an excellent question, and I probably come across this one weekly. What this would tell me is that the family doctor is a little nervous and does not have knowledge about sickle cell disease, which is okay, because the patient who comes to our clinic, we are their sickle cell experts and we can help with anything that's sickle cell related. So we always want to make sure that our documentation goes back to the primary care provider and it provides that knowledge to the primary care provider. So in other times, sometimes it just tells me I need to have a conversation with that family doctor and can contact them. And people are very supportive. And there's always a health naivety when it comes to a sickle cell. You know, no one wants to hurt someone, so they want to defer it to their experts. And sometimes we need to close the loop that they do need to follow up on things that aren't sickle cell related. So it's just an education gap, that's all.
Thanks, Colleen. So thank you everyone for submitting your questions. On behalf of our participants watching today and our patient education and engagement program, thank you, Colleen, Sindhu, and Bethany, for sharing your expertise and personal story with sickle cell disease. Our next health talk will premiere on YouTube on October 26th on pharmacists. We hope to see you then. In the meantime, submit what questions you have for our speakers on the topics of pharmacy, what a pharmacist does, and how a pharmacist can support you on your healthcare journey. Your feedback is very important to us. Please go to the link on your screen and complete the survey at the end of the Health Talk video. The link is also available in the description box below. We thank you in advance, as your feedback will help us know what you liked, what we can improve on, and what topics you would like to see in future Health Talks. And finally, to keep up to date with our Health Talks, subscribe to our online patient e-newsletter and get up-to-date information about events and new resources at UHN. To fill out a form to subscribe, please go to the link on your screen. This link can also be available on the confirmation page after filling out the feedback survey. Thank you again for viewing this Health Talk. We hope to see you at our next session in October.